note paper, write your suggestion and hand it over to my people so that we can take some decision for our next and future. Now, I would like to request Professor Jyoti Cbubal to present his lecture on what we should look for this. Professor Jyoti Cbubal.
You end up giving a lot of weightage to the fetus, and you tend to treat the placenta little lightly, simply because you feel that you are scanning the fetus. But then the placenta is very, very important too. So, the story of the placenta begins as early as 10 weeks of gestation, when you see a focal thickening of the choriodecidual ring, and that is the site of the future placenta. By 14 to 15 weeks of gestation, the placenta is practically well formed. You know its location, see how far it is extending. So the most common way of looking at the placenta is the trans-abdominal approach. And whenever you feel that the placenta is low-lying or any other issue, it is very, very safe to go and do a transvaginal sonography to look at the placenta. In fact, that gives you a lot more information which you would have probably missed out transabdominal. In case if a patient just refuses transvaginal sonography, then you may try a translabial approach. Of course, that requires the regular transabdominal probe. Information is definitely a little lesser than the transvaginal scan, but I think we should try and convince our patients that it is safe. Do it gently for the patient so that we can get the requisite information. So, as per the consensus statement of the Society of Maternal and Fetal Medicine, the placenta must be examined in orthogonal planes. So, we need to look at the placenta transabdominally, first in the longitudinal plane, then in the transverse plane as well. Not to forget to look at the placental cord insertion, and I will cite examples why it is so important. We should have minimal probe pressure, because if the probe pressure is more, then we may have the placenta extending caudally or maybe cephaloid, and then we may miss a diagnosis of a low-lying placenta. We need to look at the retroplacental complex. So this hypoechoic area behind the placenta is basically formed by the decidua, the myometrium and the uterine vessels. And this is a very important thing that we need to see. Next, we do a transvaginal scan whenever we suspect a low-lying placenta. Look at the edge of the placenta and see its relationship with the internal os. So coming to all the problems that we see in day-to-day practice in the placenta. So the first thing is placenta previa. Earlier on, we used to talk about central placenta previa and marginal placenta previa and so on. But now we only have two terms. A low-lying placenta, where the edge of the placenta is within 2 centimeters from the internal os, and the placenta previa, where either the edge or the bulk of the placenta covers the internal os. So here we have the cervix, and the placental edge is almost reaching the cervix, and here it is completely covering the cervix. So placenta, whenever we see placenta previa, it is very, very important to look at the cord insertion. Oftentimes, placenta previa and a marginal cord insertion go hand in hand. Sometimes with the marginal cord insertion, we may have vasa previa. So we have large vessels of the cord lying on the internal os behind the membranes. So they have gone off the placenta and they have coursed behind the membranes over the internal os. And vasa previa is a very, very serious condition if you happen to miss it. Just imagine this cervix starts dilating and those vessels will get stretched, they will tear, and these are fetal vessels. The fetus will exsanguinate in no time and we will have an IUFD on hand, an unexpected IUFD, and we cannot let this happen to our fetuses. Therefore, it is very, very important to look for vasa previa, look for velamentous insertion of the word whenever we have a placenta previa. Now, how to follow up these patients with placenta previa? So, normally when we do a scan at 11 to 14 weeks, the NT scan, we look at the position of the placenta. If it is low lying, we do endovaginal sonography. And we follow them up at 20-24 weeks during the anatomy scan. And again at 30-34 weeks when we do the growth scan. Now, if you look at the incidence of placenta previa in the first trimester, it is very high, 42%. But when it goes to mid trimester, the incidence is lower, and by 34 weeks, it is only 2%, which means all the low-lying placentae that we see in the first trimester tend to migrate up, and very few of them remain behind. Therefore, I would suggest that there is no consensus on this, that unless you see a placenta which is completely covering the internal os in the first trimester, it is better not to report, because very often you report a low-lying placenta and the patient is put to bed rest, and that really becomes a whole lot of messy thing. So first trimester previa is really very common. If the placental, even if the placental edge overlaps the internal os by 23 millimeters in the first trimester, the probability of previa is only 8% at term. So let's not overcall placenta previa in the first trimester. Now, according to the guidelines, placental localization under 16 weeks of gestation is inaccurate. There is a very high rate of previa at this gestational age. It is kind of overestimated and it is better not to be reported. After 16 weeks, we need to follow the classic definition. If the edge is more than 2 centimeters away from the internal os, it is normal. If it is between under 2 centimeters, then it is a low-lying placenta. And if it is covering the os, it is of course placenta previa. And this fetus needs to be followed up. So when do we follow up? We follow up at about 32 weeks. At 32 weeks, if the at 32 weeks, it is best to do a transvaginal scan for these patients. So if the placental edge is still covering the os or reaching the within 2 centimeters of the os, we need to follow them up again at 36 weeks. At 32 weeks, if the placenta has resolved, that it has moved away from the internal os, then we need to do a Doppler in these cases. Why? Because we need to look at the position of the vessels, and very often we see a lot of vessels in the lower uterine, lower myometrium and the cervix. We see a lot of venous channels over there, and this can bleed at the time of delivery. So we need to inform the clinician that even though the placenta has migrated up, there are a lot of vessels over there which need to be taken care of at the time of delivery. Now, if the patient is symptomatic, that is bleeding, the patient is bleeding, any time between 16 weeks to term, that becomes an indication to do an ultrasound, and which I am sure all of us know we use. So here we have a placenta which was low-lying earlier, and it has now migrated up. The distance is about 3.2 centimeters from the os. So this is one important reporting point. When we follow up the patient of placenta previa, on the follow-up scan, the distance of the edge from the internal os has to be mentioned. And then here there is another placenta which is still close, which is still reaching the os, so the previa has concluded. Now, one condition which goes hand in hand with placenta previa is a morbidly adherent placenta. And now the terminology for morbidly adherent placenta is a PAS spectrum, placenta accreta spectrum. So all those terms like placenta accreta, increta, percreta are now obsolete. We just use a simple term placenta accreta spectrum. Now, what are the high risk factors? All of us know multiparity, advanced maternal age, but these figures are really very scary. In cases who have had previous cesarean section or previous myomectomy or any other uterine surgery, the incidence of PAS spectrum in these patients is 20 times more than the normal incidence. And whenever there is a placenta previa, it is almost 2000 times more. Now 2000 times is, I feel, a little bit of exaggeration, but then this is a little better statistics to go into. Placenta accreta occurred in 0.004% of women without placenta previa, and it happened in nearly 10% of women with placenta previa. So once we see placenta previa, our antennae need to go up, and we need to look for features of placenta accreta spectrum. So the first finding in a case of placenta accreta is multiple cystic spaces within the placenta, and these are called lacunae. Now these lacunae have very low color, low velocities. The fluid is moving at very low velocities in these lacunae, and therefore it doesn't pick up color very easily. But there might be a feeder vessel, and the feeder vessel may show velocities which are in the range of about 10 centimeters per second. A very close differential diagnosis of this lacunae is placental lakes. Now, placental lakes generally lie beneath the membranes, whilst lacunae will be seen in the center of the placenta. Here in the lakes, the color, the flow, the flow is really very slow. It doesn't pick up any color, but you can see them, see the movement within the lacunae on beam mode. And if you are in doubt whether this is a lake or is this a lacunae, you can kind of do a follow-up within 24 to 48 hours. And immediately the lakes will disappear, the lacunae will persist. So that's how you can distinguish between the two. The next important step is the disappearance or loss of placenta myometrial hypoechoic interface. Now here that scanning technique where you should not put too much of pressure becomes very important. So the loss of placenta myometrial interface is an important thing. Now when you look at a normal placenta, there are vessels which are seen in the placenta and there are vessels in the myometrium, but you don't have any bridging vessels. So in the case of placenta accreta spectrum, there are a lot of bridging vessels between the placenta and the myometrium, and sometimes they may really look very ghastly on color Doppler or on CT. Then there can be distortion of the contour of the lower uterine segment. So you see that the placental tissue has gone through the entire myometrium and is trying to invade the surrounding structures, giving rise to this distortion of contour. And this distortion may sometimes cause a mass effect on the bladder. So that's how you can look for signs of PAS or ultrasound. Now there are a few important learning points with respect to PAS and previa, and I like to club the two together. Diagnosis before delivery is very important. Why? We can prepare the patient for delivery. We can have a multidisciplinary planning and reduce maternal and neonatal morbidity and mortality. So typically what they do nowadays is they try and deliver this patient in a multi-speciality hospital. The interventional radiologist cannulates the uterine arteries, The baby is delivered by the obstetricians, the pediatricians take charge of the baby, and the moment the baby cries, the uterine artery is embolized, and that really reduces the incidence of bleeding. But if that is not possible for some reason, at least keeping blood ready, being prepared to tackle hemorrhage, and all those things can be done if the diagnosis is made accurately. Now, grayscale ultrasound is very sensitive and specific for the diagnosis. But whenever we have a posterior placenta, which we can't see very well, a posterior placenta previa, or we have suspicion of invasion of surrounding structures, it is probably better to ask for an MRI in these cases. It is probably better to deliver these fetuses close to 36 weeks of gestation in a tertiary care center in a multidisciplinary team. There is a new school of thought about managing these patients. So they deliver the baby and leave the placenta behind in its entire extent. It is, they believe that this reduces the bleeding, and over a period of time of average around 6 months, the placenta gradually sloughs and falls off. So there are some people who believe that. Now we saw how we can identify anomalies in the first trimester. So can we predict past and previa in the first trimester? Yes, there are a lot of simple methods of doing this. So what we do is in early pregnancy, before 10 weeks of gestation, we divide the entire uterine cavity in two halves by a transverse line. And if the gestational sac lies below this line, then there is going to be a good chance of a placenta previa and eccrita. Along with this, we try to look at the niche. Now, what is this niche? This is actually the previous cesarean scar. I think a lot of people like to call the fluid in this scar as isthmosine. So, if this thing is present, we should see if the gestational sac, the low place gestational sac, is it insinuating into this niche? Then there is a chance of placenta previa and eccrita. We also like to measure this residual myometrial thickness, and if this is less than 2 millimeters, then we know that there is a possibility of placenta eccrita. There is one more sign in this context known as the crossover sign. So what we do is we draw a line along the cervical canal and the endometrial cavity. And if the sac lies anterior to this line, this is known as crossover sign or COS1. And the chances of eccrita are very high, placenta eccrita spectrum. If this line crosses the gestational sac, then this is known as COS plus 2. Chances of eccrita are about 50%. And if this gestational sac lies posterior to the line, then it is COS minus 2. So we can predict this very early in pregnancy, and then the patient can decide what she wants to do, whether she wants to terminate that pregnancy at that time, or maybe take the chance of going through a fast spectrum and its complications. Now, when it comes to late first trimester, typically during the MT scan, the features of past are very similar to those seen in the mid trimester. So we can look at those features and identify them. The other common problem that we see in day-to-day practice is a subchorionic hematoma. Commonly, we see it in the first trimester, and we do nothing. We just conserve these patients, and most of the times this gradually disappears. But they say that whenever the size of the hematoma is as large as the gestational sac, the chances of the prognosis of that particular pregnancy is relatively poor. So we need to counsel the patient at that time. Next, we go on to placental ablation. This is actually premature separation of a normally implanted placenta. So normally located placenta, when it separates before the baby is delivered, that is placental abruption. And the incidence is around 0.5 to 1%. Now this has a very classic clinical trial. Now what is it? Patient complains of severe pain, there is vaginal bleeding, there is uterine tenderness. And if you ever get a chance to see such a patient, just put your hand on the abdomen of the patient. The uterus feels stony hard. Once you see this, you will never forget it. And if you see that in any patient, you will hunt for a placental, small or large placental abruption and a retroplacental hematoma. Now the appearance of the retroplacental hematoma depends upon the times in anybody. In the first 48 hours, it is hyperechoic, looks very similar to the placenta and is likely to be missed. After 48 hours, it becomes isoechoic with the placenta. Again, it is likely to be missed. And then, of course, it becomes hypoechoic. Finally, it dissolves and becomes anechoic. And that time, of course, you can see it very easily. So this is a very, very bulky placenta, and you can see mobile echoes over here, suggestive of placental hemorrhage. That hypoechoic area behind the placenta is the hemorrhage. And because it is hypoechoic, you know that it is more than 1 week since it has happened. And here, of course, this is a fresh hemorrhage which is hyperechoic and very difficult to differentiate from the placental substance. This was a very recent case of ours. She had bleeding and somebody said that there is an accessory lobe of placenta and it is low lying and that's where she is bleeding from. So when she came, she had these images before us. So that was the accessory lobe. But gradually what we saw was, by the time she came to me, it was more than a week. The hemorrhage was looking hypoechoic and finally it disappeared and she never had any accessory lobe. So they had mistaken the acute hemorrhage for an accessory lobe of placenta. As we said earlier, sometimes placental lakes can mimic placental hematomas. So again, we know how to differentiate the two in this case. Now the normal placenta is usually a single discoid placenta, but sometimes you can have an accessory lobe, or sometimes you can have the two connected with a very fine membrane. Now why do we worry about these situations? Once the placenta is delivered, sometimes the accessory placenta may be retained behind and cause bleeding and all those things. Whenever there is an accessory lobe, it is very, very important to look for the placental cord insertion, because oftentimes the cord insertion may be on the membranes between the two lobes of the placenta. And when the when the placenta is delivered after the baby is delivered, at that time, because the cord is attached to the membranes, it may break and both the placentae may be retained inside. So these kind of complications can happen whenever there is an accessory lobe of placenta. Then we sometimes have a circumvallate placenta. So normally the membranes go along the edge of the placenta and go onto the myometrium. But here a part of the placenta is kind of interned and the membranes go onto this part. And this again can be a source of hemorrhage and filamentous cord insertion. Then placental calcification. Few years back we used to grade the placenta based on placental calcification. But now we know that